Good morning. My name is Doug, and I'd like to welcome you here, those of you who are here and those who are online, to our keynote address. But before I do that, I wanted to talk a little bit about JB Mwangi Memorial organization and what it is, right? So this is an organization that was started earlier this year by a group of friends that came together in honor of our brother JB Mwangi, who we lost last year to colon cancer. And we started this organization mainly to be able to take care of a lot of the needs that we experience as a community. We found also that it's important to get our community educated on testing, which was one of the things that he was very focused on. He wanted people to be educated about testing so that you don't end up going through the difficulties that he went through. And also, we know as well that some of the common things that afflict our community include things like heart disease, diabetes, high blood pressure. And so part of what this organization is focused on is to create awareness. We want to make sure that we especially target the underserved communities, the black and brown communities especially. We want to make sure that we provide information, education, and any pro bono services, such as the ones being provided today. So the key goals for this organization, like I mentioned, is education, especially on early cancer diagnosis, sharing information on what is available in as far as health and wellness resources, and also providing any sort of services that especially diagnostic services that we can be able to provide. This organization will continue providing this through things such as what you're seeing today, this health fair. We are also going to do educational events and also set up any sort of diagnostic avenues that people can be able to use. Before I invite our keynote, I also wanted to take this opportunity to thank all the providers that have shown up today and are continuing to partner with us. We want to especially acknowledge Parkland's health system that has brought a lot of services from their community outreach program. We also want to acknowledge, thank you. We also want to acknowledge each and every one of members of our community who are practicing medicine. There are clinicians out there with a lot of organizations, including Baylor, Texas Health Resources, and so on and so forth, including some that have their own private practices, Dr. Juma, Dr. Njeri. A lot of you have come out here and you're providing your services for free. Our goal as an organization is to continue leveraging that so that we provide this avenue for you to continue giving back. I know you already give back in a lot of other places, but we wanted to make sure that we provide you another avenue to be able to give back to the community, share, educate people, so that we can be a healthier and more knowledgeable organization, group of people. So again, like I mentioned, we hope that this health fair is going to be annual. We are also going to have additional events that we will share through the same processes that we shared today, and so be on the lookout for that. And so without further ado now, I'd like to invite our keynote speaker, Dr. Gaitande, is with the Texas Oncology Organization. He is also a surgeon, practices with a lot of organizations, including, Baylor Scott and White, Medical City, Texas Health Presbyterian Hospital, and other places. Some of the procedures that he performs include things such as pancreas. Some of these things I'm not like, so if I butcher any of these things, please excuse me. But things like pancreas resections, gastric or stomach resections, esophagus resections, liver, a lot of complicated stuff. So we are very happy that Dr. Gaitande has agreed to partner with us, to come here to be a keynote, and continue to partner with us to educate our folks, to help us be able to get people healthier and people more knowledgeable about the challenges that come to us from a medical perspective. So without further ado, Dr. Gaitande.
Oh, he's tall. All right, so hello. Can everyone hear me okay? All right. So hi, I'm Shravan Gaitande. I'm a surgeon with Texas Oncology. We're good. I am a surgical oncologist, so what that means is I'm a surgeon that specializes in surgery for cancers or tumors, and primarily those are cancers and tumors in the abdomen, so stomach, esophagus, pancreas, liver, colon, but I also do general surgery as well. But I'm not here today as a surgeon, so I left all the sharp instruments at home. I just wanted to take an opportunity to talk to you guys today about colon cancer and address hopefully some issues that are a little bit more specific to our audience today. As a little bit of background, so I grew up in Texas, in a small town in southern Texas. Unfortunately, now everybody knows where it is because it's Uvalde, where the shooting was. But it's a small town, and I grew up there when both my parents moved here from India in the early 70s. So I'm a first-generation immigrant. So I hope that some of that background can help understand maybe some of the issues that can be more cogent to the population here today. But hopefully, the information that you gain here today can be applicable to everyone. So I don't have control of the slides, but you can go to the next slide. So let's just start with what is colon cancer. So we're going to talk primarily about colon cancer, and if there is a question, I think there's some time at the end for questions, but please don't hesitate to stop and raise your hand. But colon cancer is cancer of the colon. The colon is what is often referred to as the large intestine. So it starts down here in our right side, and it runs kind of like an like a question mark through our abdomen. And it's our large intestine, so colon, and then the very end is considered the rectum. And so all of the cancers or tumors in that area are called colorectal cancers. And that organ itself is quite large. It's about 5 feet long. And cancer can occur anywhere in that, or actually anywhere in our GI tract. You can go to the next slide. I think they lost us. Yeah, there we go. So colon cancer is important to know because it is very common and quite severe cancer. So in this country, most recently, it's the 3rd most common cancer in both men and women, and it's the 2nd leading cause of death from cancer in the United States specifically. What's important, and if we took one thing away today, is that colon cancer is not only diagnosable, but is actually one of the few, or maybe even only, cancer that's preventable, and we'll talk a little bit more about that. Next slide. I'm going to take this off so I can move around a little bit. All So first of all let's start with who is at risk for colon cancer. You can go to the next slide. The easy answer is anybody with a colon. So there are some predispositions that some people believe it's more common in men or more common in women, but it's actually fairly equivalently distributed between men and women, maybe with a slight increase of incidence in men. And over the lifetime, about 1 in 25 individuals will develop colon cancer. In 1990, it showed that the risk of colon cancer had dramatically elevated, so twice that than it was just in 1950. And that's just in the United States, but that has a lot of factors that may have contributed to that, and we'll talk some about those. Next slide. What causes colon cancer? So there are a lot of factors that we know are associated with colon cancer, and we don't know if it's one single cause, but certainly things that increase the risk for somebody to develop colon cancer are some things you can't change: your age, your ethnicity, your family history, but then there are things that you can change, such as your activity level, whether or not you smoke, your diet or dietary intake. And so there are some controllable risk factors and some non-controllable risk factors. Next slide. There are some other factors that can contribute, although less commonly. So things like history of radiation to the abdomen or any sort of inflammatory bowel disorders that somebody might have been born with or developed. And so it can be a quite complex equation, but when we see that those are on the slide there, those are the risks or things that are associated with the highest risk of colon cancer. What I would like to point out is 75% of patients that are diagnosed with colon cancer do not really have a screaming risk of, say, family history. And so 75% of people diagnosed with colon cancer in this country are diagnosed as what we call sporadic or random. And so it's not that every person in your family or a lot of close relatives have to have had cancer for somebody to develop cancer. If you have a colon, you can get colon cancer. Next slide. I know this is kind of small, but what I also want to point out, and this is probably the most concerning slide. So if we look here, the left side is men, the right side is women. It's hard to see, but the darker line, which is actually blue, I'm sorry, the darker line is blue, which is female. The top line is green, which is male. And if you look, it's really, really hard to read, but it's separated out from the standpoint of age. So the very top one is from 0 to 49, the middle one is from 50 to 64, and the bottom one is over the age of 65. And what we see is that older patients have a decreasing incidence of colon cancer, but younger patients have an increasing incidence of colon cancer. Some of that is attributed to the way we are diagnosing colon cancer, but some of that is not something we have a good understanding for. So the incidence of colon cancer is rising in the young population, and that is actually one of the few cancers that's incidence is rising in this country. So most cancers, the incidence is decreasing, but colon cancer, especially in young patients, the incidence is rising. Go to the next slide. So what are the symptoms that might be associated with colon cancer? And so we think that, well, if the incidence is rising, the best way to understand if somebody has a risk or when they should get checked is based on symptoms. But unfortunately, most early colon cancers do not have any symptoms. The reason for that is multiple, but when you walked through that tunnel today, that was a description of your colon. And while our colons are not that big, our colons are designed to be like a balloon, designed to hold our stool. And so something small, like a polyp or a small colon cancer the size of a pea or a grape, may not cause a blockage, may not cause any symptoms that make somebody aware. So waiting for symptoms to begin screening or surveillance for colon cancer is not the right thing to do. I said if you took one thing away, it was the early one, but if you take one thing away, we're going to have several one things to take away today, is that screening for colon cancer or surveillance for colon cancer should be performed independent of any symptoms. If we wait for symptoms, we've waited too long. All right, next slide. I probably say this a bunch of times. Now, there are people that can develop symptoms, and symptoms do not always mean that it is late stage. But symptoms can be abdominal bloating. The most concerning symptom that should never be ignored is blood in the stool. And there are a bunch of reasons that are not cancer related to get blood in the stool, but you should talk to your medical provider if you ever do notice that. Any change in the shape or caliber of the stool, and that, right, there's a lot of reasons that we might have that, even just dietary intake or our own bodies. But blood in the stool, weight loss, or if you get your routine labs and your doctor says you're anemic, that anemic means your blood count is low, and you can be slowly losing blood and maybe not even see it. One of the things I want to stop here and talk about is, what is blood in the stool? I mean, everybody knows what blood in our stool is, but we may not notice blood in our stool as red blood filling the toilet. Right? Typically when we see blood in the stool, and I know this is weird things to talk about, but sometimes just talking about them makes it easier. Most people do not look in the toilet after they've done their business. It's something, I know this is going to seem weird, it's something I want you to do. Because if you start to notice changes, those are early changes that we may be able to act on sooner. So blood in your intestinal tract gets digested by the enzymes in your digestive tract. And when blood gets digested, it turns a dark color, almost like coffee grounds or black. So if you notice that your stools are very dark, very black, that could represent blood, not just bright red. That makes sense? And so you just have to notice that there can be changes that don't seem very obvious. On the other hand, you could actually have very, very red stools and not have blood in your stool. Beets. Somebody eats beets, your stool will turn red. You drink red Kool-Aid, your stool can turn red. So the idea that there's a color in there that hasn't been there is not overtly alarming, but you really want to be paying attention. Next slide. I can't read that. Okay, yeah, so why is it important to do colon cancer screening? Well, it's obviously important because we want to be able to diagnose cancer when it's early. That part is easy to understand. The earlier, and this is true for any cancer, colon cancer, pancreas cancer, breast cancer, every single cancer, there's not one that violates this. The earlier the cancer that is diagnosed, the better the outcome. Independent of age, independent of sex, independent of ethnicity. The earlier stage, the better the overall survival. But for very, very few cancers, and certainly this is really the only one of the common cancers that we can actually prevent. So we can prevent smoking, or at least dramatically decrease the risk of smoking by lung cancer by not letting people smoke. But colon cancer, we can actually prevent. And the way we can do that is through screening and through colonoscopies. So that's a really, really big point to take away. Next line. Oh, there's a slide to show it. So prostate, can't prevent prostate. Can diagnose it early by going to your doctor and getting checked regularly. Breast cancer, I think there's a lot of awareness on breast cancer to do self-exams and surveillance with mammograms, and certainly can be diagnosed early. And again, earlier diagnosis, better outcomes. But colon cancer can be prevented through screening. And we'll talk a little bit more about that here in a second. Go ahead. So the United States, right, third most common cancer in men and women, and yet it is preventable. At some level, you could make a pretty good argument that almost no one in this country should get colon cancer. You could also make an argument that it's not 100% preventable, but the screening methods to identify it can help to identify it before it is cancer, or before it is pre-cancer. Next slide. Next slide, yeah. There we go. So the way we can do that is because all colon cancers start as a polyp. A polyp is, and hopefully you saw it on the thing outside, but a polyp is just a growth of abnormal cells in the colon. So our colon is essentially a long tube, just like a long pipe that connects our small intestine to our bottom so that we can get rid of waste. And as those cells that line the tube become overused, you shed them out of your body. But occasionally those cells can mutate and become abnormal and can start to grow into a polyp, which is just a small growth, almost like a grape hanging off the inside of that tube. And if that grape is allowed to grow large enough, and over time, that grape can then become a cancer. So if you had a colonoscopy that saw the polyp and removed that polyp before it turned cancerous, they have prevented that polyp from becoming cancerous. This is how we can prevent colon cancer. There's a lot of variables associated with that. Not every polyp becomes cancer. And it is not predictable or routine to say, I have a polyp today, had I not gotten a colonoscopy, that would have been cancer in 1 year, or 3 years, or 5 years. It's still different for every individual. But every single colon cancer started as a polyp. And so if we get our colonoscopies on time, 90% of the colon cancers in this country could be prevented. Polyps look different. There's a lot of variabilities why somebody might have had a colonoscopy, and then still develop colon cancer. And if you look at this picture, none of y'all should know what the inside of a colon looks like, but it is typically kind of an orangish, has some blood vessels that run it, and they're smooth. So that top left picture, that's pretty obvious. You would never have had to see a colonoscopy to say, well, there's something there. But the bottom right picture is a very small polyp, and it's a flat polyp. And flat polyps often have a slightly higher incidence of developing into cancers. So they can all look different, and so the idea that you get a colonoscopy once and it was normal, or hey, they took out a couple polyps, I'm good for the rest of my life, is not true, because there are polyps that can be missed, and there are polyps that grow at different rates. So there's pretty standard recommendations for what happens if you have a polyp. But as a general rule, these are cancers that are pretty slow growing. So if I got a colonoscopy today and it was completely normal, I don't need another colonoscopy for 10 years, unless something changes. So for those that are hesitant to get a colonoscopy, it's just 1 day in 10 years. All right, that's not bad. We do a lot of things more often than that we don't like to do. Next slide. So I know I keep saying this because it's really important, is that the colonoscopy can prevent colon cancer. And if we stay on top of it, we can avoid getting more significant problems. Now, I should take a step back and say, if somebody had a colonoscopy and they did have some polyps, which is very, very common, then they don't get to wait 10 years. Because you had polyps, your doctor will give you a recommendation. Typically, it's every 5 years thereafter. Depending on the type of polyp, the size of the polyp, it might even be every 3 years. But you have to start with one. Go ahead, next slide. And this is kind of a depiction of that. So you can see on the top picture, there's a polyp, pretty obvious to see. And then the bottom left picture is where they've taken it out. So they can do that through the colonoscopy without a surgery. So no cuts in your abdomen, no scars. They can do it right when they're there. What makes it look like it's blue is the GI doctor will often put a little tattoo ink in there, so that if, when they test that thing on the bottom right, which is the polyp that's now been removed, they send it to the pathologist can tell us, was there cancer there, was there not? Even sometimes when there's cancer there, taking that polyp out is all that patient would need. But if it was larger and there was more cancer, then we may want to go do more surgery. And it's hard to know where in that 5 feet of colon this polyp was looking at it from the outside. And so the GI doctor can leave a little blue tattoo ink so that I can find it when I go do surgery. And so that's what that looks like from the inside. Go to the next slide. So the take-home point there is, what should you do if you're completely asymptomatic? You should still get screened. So there's no reason why somebody should not get a colonoscopy screening, colon screening, unless you don't have a colon. Then you don't need to go looking for it. Next slide. So what is screening? And there's several different types of screening. I've said the word colonoscopy at least 25 times. So if you leave here and you don't know colonoscopy is a way to screen for colon cancer, I've failed you. But there are actually other ways. Colonoscopy is by far the best way from a recommendation perspective because of the idea that you can treat the polyps at the same time. But there are other ways. So they're kind of distinguished between 1 and 2-step screening tests. So 1 step is the colonoscopy. So I get my colonoscopy. If they have a polyp or a mass or whatever it is, they often can treat it at that very instant. A 2-step screening test would be something like the cards that we see on the TV commercial with the guy that dances, and that's called the Cologuard. And there are other brands and other ways that test for different things in our stool. So what's been around for a long, long time, 20, 30 years, is called a fecal occult blood card. So it's a little, almost looks like a index card that you put a sample of stool on and put a little liquid on, and if there's blood in there, it'll turn a color. So if there's blood in your stool, you need to do something more. So the fact that there's blood on that card, it turns the color, does not mean that somebody has colon cancer. It just means there's blood in the stool, and so that necessitates a second test. That's the 2-step. And so there's a bunch of them. We can talk about a few of them. Go to the next slide. I talked about colonoscopy. You can skip that and go to the next one. Yeah, so and FIT is fecal immuno testing. And so that tests for the blood. There's different ways they do it, different portions of the breakdown of blood products that they can test for. But if somebody was to do that, they need to do that every year. Why would somebody do that over a colonoscopy? There's not a medical reason. Well, not a good one. So if somebody says, well, I want to get the best test, it's a colonoscopy. If your doctor says to you, your heart is really, really bad, your lungs are really, really unhealthy, you're allergic to the medicines that we might give you for sedation, these are all pretty uncommon, then maybe doing a lower risk test, which is just putting a stool sample on a card, is the right thing for each patient. So again, it's a conversation. The box that dances on the commercials is a multi-target stool DNA test. And there's a few different ones, but what it actually looks for is not blood. It looks for proteins or DNA that might be associated with an increased risk of colon cancer. And what it really is testing for is the proteins or DNA that might be associated with precancerous polyps. So if those proteins are present in the stool, it necessitates a second test, a colonoscopy. The second test is always a colonoscopy. If those cards, and the way it works is you get online or you go to the doctor and they send you a kit, and you do it at home and then you turn it in. And over about a week period, they test that and they give you a result that you can check online. And if it's normal, the recommendation is that that person does not need to redo that screening test for somewhere between 1 to 3 years. This is a relatively new test, so we don't know exactly what the right answer is, and probably in somebody who does not have a high risk. So an otherwise healthy person that doesn't have a bunch of family history for colon cancer, probably 3 years is okay. And if there maybe is family history, or maybe you're a smoker or have ulcerative colitis or other high-risk factors, then perhaps you should do it every year. But it is a good alternative for somebody to get their colon cancer screened. Next test. I think there's a picture that can kind of show it. Sorry, next slide. Yeah, there we go. That's really small. So yeah, the one-step test, colonoscopy, and then if the two-step test, if it's normal, you don't need to do anything more. If it's positive, you got to go back to the colonoscopy. There's a couple things I want to talk about on this slide. So I keep saying colonoscopy. Well, what actually is that? What happens in that process? I don't want to put anybody on the spot, but who here knows somebody who's had a colonoscopy? Let's go with that. Okay, so a fair amount of people. So what it entails is a colonoscopy is just a camera. The camera is attached to a long tube because our colon is 5 feet long. So to be able to look at the entire colon, the camera has to go through the whole process. So the tube is about 5 feet long. And what happens is your doctor places that camera in your bottom and goes the backwards direction. So normally everything goes this way, goes the backwards direction, inflates it with that balloon with air so we can see all the walls, and goes and checks the whole process. That is done with somebody asleep, so it's sedation, although you're still breathing on your own, you don't have a breathing tube in your mouth. And some patients might remember going into the room or coming out, but most patients don't have any recollection of it. As soon as it's done, other than feeling a little gassy, there's no pain associated with it. It takes about 25 minutes from the moment they start to the moment that they're done. And if you've talked to somebody who has had a colonoscopy, the worst part of the the second worst part of the colonoscopy is the anticipation of the colonoscopy. Nobody really wants to have that done. It's not that bad. The bad part is the prep. There's just no way around it, right? In order for the colonoscopy to be adequate, you want to be able to see all of the colon, and the colon's job is to hold stool. So you have to get that cleaned out. And the way you clean that out is there's different medicines that your doctor can prescribe. Some is like 2 big milk jugs full of this kind of thick water. Some doctors add pills with that. And what it does is it makes you go to the bathroom about 10 times more than you want to. So the night and the day before you start drinking that, and I wish I could make it sound not so bad, but it's just not fun. But as soon as the colonoscopy is over, you're back to normal. You can do whatever you want. And hopefully, you only have to do that once every 10 years. Going to the bathroom 10 times in a 5-hour setting is not fun. But having 6 months of chemotherapy or a surgery that cures you, but the 3 weeks of recovery associated with that is far less fun. So it's kind of the worst, the best of the evils. And not that this is a good reason to do it, but there was a time period in this country 10 or 15 years ago where it became fashionable and celebrities said you would lose weight and you would be less depressed if you got your colon cleaned out. You can even get online today and buy juice cleanses that clear your colon out to make you feel better. I don't know if those work or not, but if it makes you get a colonoscopy, sure. All right, next slide. Or does that say? Oh yeah, so the screening record, when should you get a colonoscopy? So colonoscopies, up until about 5 years ago, the recommendation was you should get a colonoscopy starting at age 50, or 10 years prior to a first-degree relative getting cancer. So if you had a 40-year-old that got colon cancer, your brother, your father, so it has to be a first-degree relative. Grandfather doesn't count. 10 years prior to that, because it, at least in general, takes 10 years for a polyp to develop into colon cancer. That has been changed now because of that slide I showed you in the very beginning. So now, because there's an incidence rising of colon cancer in young people, they have changed that recommendation to 45. So anybody in this room who is over 45, who has not had a colonoscopy, on Monday you're going to call your doctor and you're going to say, I need to get scheduled for a colonoscopy. You're going to do that because it takes months to get in for a colonoscopy. It is not a test that you can call and 2 days later get. It takes, if you called your doctor today, they're going to tell you we can do it in April. And that's okay. April is better than not getting it. So anybody over the age of 45 or anybody who has symptoms. So this is purely screening. If you start having symptoms, that's considered diagnostic, not screening. Recommendations for diagnostic colonoscopies are different. But for screening, it's starting at the age of 45. And then depending on the findings of that colonoscopy, your doctor will tell you when you next need it. So if it's stone cold normal, once every 10 years. If there's a few polyps that are low risk, once every 5 years. If there's more, once every 3 to 5 years. If they see something really abnormal, maybe even every year. That's pretty uncommon. But the most is typically 3 to 5 years if there was a bunch of polyps. Who should do those other ones? We talked about if you're, heart is bad, lungs are bad, or if the risks of the colonoscopy are too high. Or if we're being completely transparent, some people say, I'm just not going to do a colonoscopy. I'm going to tell you that my father is 75 years old, his son is a cancer surgeon, and I still have not convinced him to do a colonoscopy. I can't. But I did convince him to do the Cologuard. And we had the understanding that he would not get to see his grandkids if the Cologuard came back abnormal and he didn't get a colonoscopy. Now, that doesn't make it okay, you should still get a colonoscopy, but there are some people that do not want to have a colonoscopy. And if you're not going to do anything, at least do the Cologuard or one of the card tests as a start. Next line. And then we talked about that. So the testing, it says every 1 year there. It can be up to every 3 years, depending on somebody's risk. And then here are some of the other tests. So flexible sigmoidoscopy is, instead of looking at the entire 5 feet, they just look at the last 2.5 feet, which for the average population is where the majority of colon cancers are. It's more common on the left side. It's a little bit easier test. You don't have to drink the prep. You can take an enema. I don't know why you would do that if you could just drink something, but, and it does not have to be done under sedation. It can be done with somebody awake. So some people opt for that, but because you're not looking at the whole colon, it needs to be done more often. And then there are CT scans these days that can see the colon. Capsule, so you swallow a camera that goes through that can see the colon. All of those are inferior to what we've already talked about, but they are far superior to doing nothing. So something is better than nothing. The one thing I'll say is that we have really fancy tests, and so the tendency would say, we have all this advanced medicine, can I get a blood test? No. There are blood tests associated with colon cancer, but not for screening. So the men in here might know that my doctor sends a PSA to look for prostate cancer. There's not something like that for colon cancer. So no blood test replaces the other things we've talked about. What's the next slide? I might stop here. Okay, before I go to that, this next slide, a couple issues you should be aware of. Issues that don't really have anything to do with medicine, but have everything to do with medical care in this country right now. So one of the reasons why somebody might not get a colonoscopy is it's hard to get to a doctor, or I don't have insurance, or both of those. And so the Cologuard is a nice alternative for somebody who's not going to get a colonoscopy. But you need to talk to your doctor or your insurance company if you think you want to do one of those instead of a colonoscopy for a very specific reason. So if your insurance became active, or if the policy became active after May of this year, then this doesn't apply to you. But if it was active before May of this year, the insurance companies look at tests as either screening or diagnostic. So screening means I'm going to look for a problem. Diagnosis means we think there's a problem, we need to figure out what it is. The colonoscopy that is done for a screening colonoscopy versus the colonoscopy that's done as a diagnostic test is the exact same colonoscopy. But if I went to my doctor and I said I have bleeding, they're going to do a diagnostic colonoscopy to figure out why I'm bleeding. It's the same test, but because of the reason why we're doing the test, insurance coverages are different. Every single insurance company, from the really, really good ones to the ones that are not considered good, and Medicare and Medicaid and everything in between, screening, a colon screening test is covered by insurance. Now, what I want you to check with your doctor and your insurance company for is if you did a card test. You said, well, maybe I'll just do this because it's 4 months to get a colonoscopy, I'll do this card. If that card test comes back as high risk, there was those proteins and we need to do a colonoscopy, that colonoscopy is now considered diagnostic, not screening. And so sometimes insurance company coverage is not the same for those, depending on your insurance company. So, if those issues are issues that might make it hard for you to do a test, is to say, hey, if it's not covered or if it's not 100% covered, I don't know that I can currently afford to do that test. Don't do that first one, because you can get a colonoscopy that's 100% covered. When you haven't had another test, it's screening. Does that make sense? So that's an important and just unfair thing to know. There's public policy in place to try to change that, so that if somebody got another test and it was abnormal, that the diagnostic colonoscopy to follow will be covered. And if your insurance became active after May, that is true. But for people whose insurance has already been active, it is variable from policy to policy. So check before you order the Cologuard. There's not a Cologuard rep in here, is there? Okay, good. All right, next slide. Oh, sorry, you could stay here for a second. So I want to talk specifically about the African American population. And when I say African American population, it is difficult in this country to really define what that means from a individual to individual. What I mean by that is, in this room, we have a lot of people who are of African descent, born in Africa. When you look at these studies and what I'm going to talk about a little bit, when we look at African American, that includes American born as well as African born. And those numbers are not the same. But the African American population as a whole in this country is the largest ethnic minority that represents colon cancer, and their incidence of colon cancer is on the rise. The young male African American population is the reason why the recommendation was changed for people to get screened at 45. All ethnicities, all genders came from the marked increase in the African American male population. And so we're going to talk a little bit about that. Next slide. But I want to make sure to cover a few more things. Yeah, so in this country, compared to Caucasians, the incidence of colon cancer is increasing in African American populations. They are developing colon cancer at a younger age, and they tend to have more aggressive biology, meaning less responsive to medication treatments. And the result of that is there's a reduced survival in the African American population compared to the same age non-African or Caucasian. Some of these don't include Hispanics because their outcomes are somewhere in between. So minorities, but specifically the African American population, has a decreased survival. There's a bunch of reasons why that might be. I think I talk about a few of them. Next slide. Yeah, so there we go. So again, I'm going to harp on colonoscopy because even in that population where the incidence is rising, where biology might be a little bit more aggressive, where the outcomes are not as good as the Caucasian population, even in those populations, diagnosed at an earlier stage, patients do better. So the very top line that's kind of a maroonish brown, that's localized colon cancer. And if you look, over a 5-year period, the survival rate is 90%. The pinkish line that's third from the bottom is colon cancer that is distant or spread. And the 5-year survival is 10%. Those are dramatically different. So even in that population that has a little bit more aggressive disease, early diagnosis is paramount. As a comparison, pancreas cancer is the other lines that you see. The differences are not as dramatic. We all hear on TV how aggressive pancreas cancer is. The Jeopardy guy died of pancreas cancer. So yes, even there's a slight difference between early and late diagnosis, but not as dramatic for colon cancer. So A, if I got my colonoscopy in time, I might prevent getting colon cancer. And B, if I got it, even if I had colon cancer, I'm more likely to get diagnosed early and really benefit from treatment. Now, everybody in this room can attest that that still doesn't prevent people from having problems and succumbing to colon cancer, but it's our best chance that we have right now. Next slide. So to hammer that point home, and we were talking about a little bit about it earlier with a smaller group, but I don't know what the African American population density is in Delaware. It's probably not as high as it is in other places. But in Delaware, they looked at these numbers that were going up and they said, we need to do something specific for this population. And so they instituted a comprehensive screening policy, which basically was to say, we are going to provide insurance coverage for people that didn't have it for colonoscopies, and we are going to try our best to make every colonoscopy available for everyone who needs one. And they did so by improving awareness and access to it. So they paid doctors to be able to do the colonoscopies, so there was more doctors available to do them, and they covered them for people that didn't have insurance. And they did this over a few-year period. If you go to the next slide. It worked. So the colonoscopy rates in age-matched black versus white Americans was significantly improved. So on the right, that was 2001. I'm sorry, on the left, it's 2001. We're just going to look at the light blue, which is black males. They went from 45% in 2001 to 75% in 2009 over an 8-year period. If you look, the incidence of colon cancer when that happened, so the dark line is the incidence of colon cancer, went down, right? So people will say, and we recently had the COVID pandemic, and independent of your politics, people would say, well, if we're doing more tests, we find more people who have COVID. And that's probably true for a lot of things. Not for colon cancer. They did more colonoscopies, and incidence, which means the amount of new diagnoses, went down. And that's because they were preventing more of them. It's that same point we tried to hammer on earlier. Another thing I want you to notice is the dark line is mortality. So when black males in 2001 that had never had a colonoscopy, 45% had never had a colonoscopy, 55% had never had a colonoscopy. The mortality associated with that was 65%. If you compare that to the bar next to it, for white Americans, black Americans had more mortality. They did education, screening, prevalence, and in 2009, the incidence of colonoscopy matched the incidence, the incidence of colonoscopy in black Americans matched the incidence of colonoscopy in white Americans, and the mortality became the same. So that disparity that we saw beforehand was reversed. It's not only that. There's biology differences, there's a bunch of differences, but one of the big ones is access and willingness to do this. And you can see it there. What's even more important, if you go to the next line, is when you see it this way. So, black Americans were still being diagnosed with colon cancer through this time. But the proportion of colon cancers that were diagnosed during this 8-year period went from being less than 20% localized to 50% localized. And I'll let you guess what happened to the survival outcomes with that, with just that. In the next slide. So 2001, 99 to 2001, about a 75% increase in mortality for African Americans compared to Caucasian whites or non-Hispanic whites. And only 8 years, the outcomes were essentially the same with just doing a colonoscopy. Nothing else was different. So certainly a big proportion of why there's disparities in this country can be contributed to access to care. I didn't go through all the details of that study, but how did they improve access to care? They did make it easier to make it affordable. And they did get more doctors available to get patients to them. They also went to community leaders in specific groups, like church groups, or youth groups, athletic coaches, people that had trust and faith of their community gave them this information, and they encouraged their followers and their friends and their family to get these tests. So some of that is also an understanding and a comfort level with the recommendation. Next slide. This is prevalent in some fashion across all cancer. So this is not just colon cancer, this is all cancer. And while there is still a disparity, you can see that there is becoming increasing awareness despite the continued prevalence and disparities of access to care. So care access has not dramatically changed in that amount of time for the minority populations, but cancer death rates have. And it's because there is awareness, because of events like this, that all cancer death rates have gotten better in the minority populations, not just the black population, but brown population as well. They all mirror this, but it's important to be able to address this disparity and know that it exists. We can see it. It's not something that we feel. It is true. It's real. Next slide. There we go. Actually, go back for a second. So one thing I want to talk about here is specific to this population. So I just said that that's, whatever words you want to use, Black Americans, African Americans, people get lumped into non-white, non-Hispanic is kind of one population. But if you look at, and one of the reasons why colon cancer in African-born Americans, so I'm going to kind of specify that, African-born Americans who are immigrants to this country, first generation, probably the majority of y'all in the room, one of the other acts, or the other barriers to colonoscopy is a cultural belief and a cultural awareness. So back home, probably not a lot of y'all hear about colonoscopy. No, probably not a lot of y'all see and hear about colonoscopy. And there's actually some validity to that. It is not that the care there is worse. It's that the colon cancer rates in the African continent are dramatically lower than they are in this country. Dramatically lower. So public awareness of colonoscopy is not that important. They have other health issues, and public awareness of other health disparities is important. For colon cancer, it's not, because colon cancer is pretty uncommon there. So you may have family back home that say, I don't know why they're worried about it. Colonoscopy, we don't need to do them here. It's probably true. They don't need to do them as much there. It's interesting, they've studied this for colon cancer and prostate cancer. And this actually is true not just for the African continent, but for my ethnicity, so the Indian subcontinent, for Japanese and Korean Americans. If a individual who is foreign-born moves to this country, you guys, the incidence of cancer mirrors or approaches that of somebody born in this country, just by moving. There's a bunch of reasons why that could be, and a bunch of hypotheses, and we don't know exactly why. Interestingly, if a American-born person moves out of the country, for most cancers, their cancer incidence starts to approach that of the country they moved to. This was actually studied for prostate cancer, which is pretty high in African males. And they looked at African-born males that immigrated here versus African Americans that had been born here and been here for several generations. And they did studies of the microbiome, or the bacteria in their GI tract, which right now there's a lot of research and consideration that might affect our risk of developing cancer. And they looked at the differences. And so a Kenyan American who is 3 generations here, their bacteria in their colon and their intestinal tract was very different than a Kenyan American in Kenya, than a Kenyan in Kenya. If you fed that American the same diet, a rural African diet, the colon bacteria starts to look more like the individual in Kenya. If you fed the individual in Kenya an American diet, their colon bacteria will start to look more like somebody who lives in this country. If you fed a white person a rural African diet, their bacteria would start to look like somebody who grew up and lived in Africa. We don't know what that means to cancer outcomes or to cancer incidence. They haven't studied it that much. But if we know that the incidence in a population is different based on where they are, you might make the assumption that the diet in this country might have a lot to do with the changes in cancer incidence. And it's probably that it does have some contribution. It is certainly not the only reason, but it's probably a large reason. So one of the other things specific in a population that in Africa has a very low cancer incidence for colon cancer, what ends up happening is the American diet is much higher in fat and much lower in fiber. And so having some awareness specific for this population of maintaining sort of cultural diets is beneficial from a health perspective. Have we proven that? No. Do I think that that is the real reason? One of them, yes. And it's interesting, right? We could spend an entire hour talking about that. Why does that work? I mean, is it body weight? Is it hormones or chemicals? It could be all of them. But it's interesting that you can take an individual and physically move them to somewhere else, and their cancer risk changes. And it's so there's a lot of reasons that might happen. But it is also the reason why maybe in talking even with a trusted family member who's a physician back home who says, don't worry about the colonoscopy, they don't need to worry about it there. But when somebody comes here, we need to start worrying about it because it becomes more common here. Next slide. Yeah, so I'm going to conclude with a few slides that are a little bit dramatic. But what are some excuses to not get a colonoscopy? So people say, well, I feel fine. That's, right? Most colon cancers are present when somebody is asymptomatic. And if you get it when you feel fine, you're more likely to prevent it. You're more likely to get diagnosed when it's early, which means you're more likely to get cured. What's another excuse? Next slide. Is that, if I'm healthy and I don't smoke and I run every day and I'm normal body weight, why would I get screened? It's because those people still get colon cancer, right? So still got to get screened in some fashion. And then the last, no one in my family had colon cancer. For you guys, this is a really big one. Because if you are first generation immigrants, it is very likely that the difference is not family history, it's environmental. And again, you have to remember, 75% of people diagnosed in this country do not have a family history. They're considered sporadic. So the fact that you don't have a family history is not a reason to not get a colonoscopy. Next slide. That might be it. Yeah. So in the end, there is no excuses to not get screened in some fashion. I would advocate for a colonoscopy, but if I can't convince you to do that, at least do the card. How do I arrange any of that? Is to call your doctor. So the American Associated Gastroenterologists have this website, gi.org. If you're not sure where to go, and they can get you plugged into for a colonoscopy, or you can call your primary care physician. It's something you should do sooner rather than later, because it takes months. Right now, if you said, okay, I'm going to go get my colonoscopy, it ends up that it's going to be after the new year, and you may have already met your deductible and you're out of pocket this year, and now it restarts in January, and so you say, well, now I'm not going to do it, just do it. Even if you want to schedule your colonoscopy for a year from now, that's better because you'll have a date, you'll be committed, and it's just once. And if it's normal, you don't have to do it for 10 years. So that's all I got, and I will take any questions. Thank you very much for your time.
I don't know about this technology. Thank you so much. Wow. Is that informative or what? Wow, yeah, please give him a round of applause. I have learned so much, and And I guess, as you said, it's okay. Let's take the drink the night before. The procedure is not that bad. So we have a few questions we'd collected before, but if you do have one, you're welcome to raise your hand. Okay. You're welcome to raise your hand if you do have one. So here are some of the questions we had collected, and I'm not going to repeat some things that are obvious, but here's a question. If I get screened once, should I get screened again, and when?
So if you got screened and there was completely normal, no polyps, no nothing, you should get screened 10 years from then, unless you got screened at the age of 70, and so if you get to 80, you might be okay not getting screened. But yes, one screening is not enough. You should get it, even if it's normal, every 10 years. If there are polyps, they might recommend getting screened in 5 years or even in 3 years, depending on the colonoscopy.
Okay. If I have a family history of cancer, am I at risk for colon cancer?
Yes. So while only 25% of people who have colon cancer have a family history of colon cancer, a family history of colon cancer significantly increases that individual's risk of colon cancer. In the Eastern African population, there's actually a fairly high incidence of something called Lynch syndrome, which is a genetic mutation that increases the risk of developing colon cancer, uterine cancer, breast cancer, some other cancers. So it is something to be aware of. If your family history suggests that you're at risk for colon cancer, then you want to definitely get it at 45 or 10 years before your first relative, your primary relatives when they were diagnosed. 10 years of their age, sorry.
If it seems or it feels like colorectal cancers have become more common, are they more common? And if they are, why?
So it's the third most common cause of cancer in this country, and the second most common cause of cancer death. So they are more common than the pancreas and stomach cancers. The why is hard. In this country, certainly the incidence of colon cancer in the United States is nearly higher than it is in every other country. That's not entirely true, but it's certainly than the South American, than the African and the Asian continents, because our dietary intake of fiber is very low. So that is a known risk factor for developing colon cancer. If you were to go and measure it, a female should get in about 30 to 40 grams of fiber a day in their diet, and a male maybe can get away with just a little bit less. And the average American diet, Western diet, gets in about 5 to 10 grams of fiber a day. If you were to say, okay, well, I'll take a Metamucil or a FiberCon or those supplements, if you look up, one of those pills is about 4 grams of fiber. So if you're only getting in 10 grams and you should be getting in 40, it would be taking 10 of those pills. So fiber, and so the pill is good, it's better than nothing, but having a high fiber diet and increasing that fiber diet not only has health benefits from a cancer perspective, but it has health benefits from your cholesterol and your blood pressure. There's really no reason not to have a high fiber diet, which is, really not that hard to do for you guys from a home, diet, because it's much higher in fiber.
Fantastic. Now, talking about diet, there is a particular delicacy that we call nyama choma, which is roasted meat, red meat, grilled sometimes on a charcoal grill. Do you think red meat is a contributing factor to colon cancer?
Maybe. So they studied it a few years ago. It was on the cover, I think, of the New York Times, and said red meat is the cause of colon cancer. Red meat is higher in saturated fats and is typically associated with a diet that is low in fiber. There are some concerns that red meat does have some inflammatory properties that increases the risk of cancer. Maybe not just colon cancer, but stomach cancer and bile duct cancers. So the best recommendation I can give is to understand that there is not a magic pill and there's not one thing that is causing it. And so it's a general overall healthy diet. So does that mean you should not eat red meat? No, you should eat red. You should not eat red meat every day. Does that mean that you should run 10 miles a day? No, but you should walk 30 minutes a day. Does it mean that if you have stress in your life, you should find a way, whether it's meditation or talking to a support group or, whatever you find. So everything is in moderation, and understanding that our body works as a unit. So diet, yes, mental health, yes, heart health, yes. But red meat does contribute if it's a large proportion of somebody's diet.
Fantastic. So you can have your nyama choma, just kiasi.
Not every day.
Not every day. So help us, this is the last question I'm going to ask unless somebody else has a question. Help us understand the survival rate numbers. What does it mean to have a 5-year survival rate after diagnosis?
Okay, that's a good question. So depending on, I don't know if you're able to go back to that slide. If not, it's fine. But depending on each cancer, there are several different ways that science defines the cancer outcomes. And they can get really complicated. So one is to say overall survival, which to everybody we would think that that's the most important outcome. How many people are alive? Overall survival actually measures just that. From the time of diagnosis, how many people when they're diagnosed are still alive 5 years later. That is overall survival. That's what it defines. Now, it does not define why that person may have died. So, for instance, if somebody is diagnosed at the age of 85 and they died at 87 of old age, their survival on that graph is still is 2 years. So it may not be the most accurate predictor of cancer outcomes, but it is a really important one because at the end of the day, we all want to know, if I get diagnosed, how long am I going to live? So what they do is they truly take every person, and these are studies, so it's not that if I got diagnosed with colon cancer today, I don't get automatically put into a computer where they follow it. But large institutions across the world and across the country have taken their patients, and if the patients have approved it, they say, okay, we're going to follow these outcomes. And in studies, they've looked at outcomes from the time of diagnosis, a stage 1 colon cancer, 90% chance that person is alive. And that really doesn't, those overall statistics don't take into account what they did or didn't do, right? So 90% of people with stage 1 colon cancer are going to be alive in 5 years overall. Does that mean that every one of them is? No. So there's somebody in that average population that died 1 year later, and there's somebody in that population that was alive 10 years later. So it doesn't mean that you're only going to live 5 years. It just means 90% will be alive in 5 years. And the same thing, the other number they see is median survival. Median survival is another way they measure cancer outcomes, and what that means is how long does it take for half of the people to have died? It's a really negative way to look at it, but median survival means from the time of diagnosis, it took 3 years, 10 years, 16 months until 50% were alive. If you were to look at that graph, for stage 1 colon cancer, we do not know what the median survival is because 90% of people are alive. Right? So it would probably be the until they get to whatever the life expectancy is in this country, because a large percentage of those people are cured. For colon cancer, generally, we would say that the highest risk of recurrence after being diagnosed is in the first 2 years. And that if somebody hasn't had a recurrence in 5 years, they probably are not going to have a recurrence. Again, there's exceptions to every rule, but most patients that have a recurrence are going to recur in the first 2 years.
So I'm not a medical person. A lot of these people are. But now I'm curious. What does stage 1, 2, 3, and 4 mean as far as cancer is concerned?
Yeah, so the technical way, any cancer, doesn't matter where it is, what cancer, the stage takes into account 3 factors. The tumor itself, meaning where this thing is, the mass, where it started, and that's called the T stage. And for every cancer, it's scored a little bit differently. But for colon cancer, the T stage is scored based on how big the lesion is and whether it's growing into the wall. And so it has a 1 to a 4 grading. So T stage 1 to 4. N stage is lymph nodes. So whether or not it was involving lymph nodes and how many lymph nodes it may have involved. And then M stage is metastasis. So whether or not it's anywhere else. And for every cancer, there's an equation or a combination. So a T1, N1 is stage 3. A T1, N0 is stage 1. And so there's they move those combinations around. So it's not the same for each one. And the reason for that is the biology of different cancers is different. So some cancers are more apt to go to the lymph nodes, but maybe that's not as worrisome as other cancers. Generally speaking, for colon cancer, stage 3 means it involves lymph nodes, and stage 4 means it's outside, it's to some other organ. So, and again, these are real general kind of guidelines, but stage 1 and 2 for colon cancer, surgery is the only treatment that is generally recommended. If somebody had stage 3 colon cancer, that's when you would consider chemotherapy, and stage 4 is chemotherapy. So generally speaking, stage 1 and 2, if diagnosed early, surgery is considered curative. If when you take it out, we take out lymph nodes at the same time, if the pathologist comes back and says some lymph nodes were involved, then probably your doctor is going to recommend that you do some chemotherapy to decrease that recurrence risk. That's kind of the stepwise progression.
Fantastic. Thank you so much. Does anybody else have a question? Okay, go ahead.
So it depends on how many they had. So if somebody, let's say, had one benign polyp, likely the GI doctor is just going to say 10 years. If you had 5 of them, they'd probably say 5 years. There are certain polyps that are more apt to develop into cancers, or what could be considered precancers, and some that are benign. And when they cauterize them, if they took it out, they'll send it to the pathologist and have that information. So benign polyp, they'll say 10 years. That kind of, so it's variable based on the polyp.
One more question. Where do polyps come from, or what causes polyps in the colon?
Not a very good, easy answer to understand. So it's at a very basic level, it's a mutation in a few genes. So every cell in our body is programmed to make and create proteins and turn over those cells. And so for polyps particularly, it's a mutation in a few genes. And the reason why somebody gets that mutation is not very well known. Smoking increases the risk of getting that mutation. Obesity increases the risk of getting that mutation. Family history increases the risk. But even in the absence of those, some people can develop those. In my cancer training, one scientist stood up one day and said something that I remember. And he said, every one of us every day is cured of cancer thousands of times. Because our body is making cells, and some cells are dying. And as it's making a bunch of cells, it's really like somebody's putting paper in a copy machine and it's spitting out copies. And there's our body, the genetic programming of our body is like somebody standing over that copy machine. And when one copy comes out kind of messed up, they're picking it up and putting it in the trash can. And that's what our body is doing the whole time. And what happens when you have mutations is sort of like saying that person who's watching the copies and make sure they come out okay, they turned away for a little while, and one bad copy got through. And then somehow that ends up in a copy machine again. And that's kind of how it starts. That process of a bad copy happens thousands of times in every one of our bodies every day. But that person, the genetics, is there to make sure it gets pulled out, And it's when that one slips through, and that's what causes it. So it's not that we did something or didn't do something, it's just the nature of how our body works. But there are things we do that increases the risk of that.
Okay, it looks like, there's one more.
I'm going to get a little closer, sorry. What was that?
How effective is immunotherapy treatment in stage 4 colon cancer?
So The answer to that is not generally well known. It's known in certain subpopulations. So let me answer what that means. So the reflex answer is for most patients, for stage 3 or stage 4 colon cancer, the most effective therapy would be chemotherapy. But there are some subtypes of colon cancer, which are actually more prevalent in the African population or the African American population, like right-sided colon cancers, that have specific gene mutations that might make them less sensitive to chemotherapy. And so in that setting, immunotherapy is often given. But the best way they tell outcomes is when they look 5, 10, 15 years later. And because immunotherapy for colon cancer is relatively new, we don't really have that answer yet. But the belief based on short-term data is that certainly for those patients that have those mutations, immunotherapy is significantly better than chemotherapy. Now, for stage 4 patients that don't have that, the presumption would be that they had chemotherapy and didn't respond or something grew. And as you get to second and third line treatments, the general idea is that they are less likely to be effective than the first one. For those of y'all that don't know what the heck I'm talking about right now. So chemotherapy, medicine to treat colon cancer, or to treat cancer. Immunotherapy, also medicine to treat colon cancer. As a general rule, chemotherapy is medicine that is a toxin to the cancer cells. It's a toxin to the cancer cells just in the way that it is a toxin to our normal cells. But normal cells have the programming, or that guy standing by the copy machine. So if a normal cell gets injured, makes a few bad copies, that guy pulls them off, and it can repair itself. Cancer cells don't have the ability to repair themselves as well. So the science is we damage all the cells because we know that the healthy cells are more likely to recover and the cancer cells won't, they'll die. That's how chemotherapy works. And there's different versions of chemotherapy that damage the cancer cells in different ways. Immunotherapy, which you'll see commercials on TV, is sort of the exact opposite, in that when somebody develops a cancer, our immune system tries its best to localize that cancer, to keep it where it is. And even if it spreads, it tries to keep it where it is there. And our bodies are good in certain cancers at doing that, and they're not very good in other cancers. But for cancers that it is good at doing, they learn that what if we just give a medicine to help the body do what it's already trying to do? So instead of a toxin that damages the cancer cells, what if we give, it's not really a vitamin, but like a vitamin or a medicine that makes your immune system do better what it's already doing? So that's what immunotherapy is. Immunotherapy is a relatively new medicine realm that has been around for 10, 15 years, but is becoming more widely used in a lot of different cancers. It's uniformly used for melanoma, which probably started about 10 years ago. And prior to that, the only other medicine that worked was approved in 1974. Right, so for certain cancers, it's dramatically changed outcomes. And there's a belief that maybe 10, 15, 20 years from now, all cancers will be treated in that way. And we're right now kind of in that middle ground of figuring out which medicines and which cancers.
Any more questions?
So the lady has left, but she left
Thank you.
instructions.
So we've heard a lot and talked a lot
month,
about
and so a month
colorectal
ago,
cancer in relates to
yes. And I was
adults.
telling her it's important that we
So
do it
what does
here,
this
so
look
that
like
we
for
can
children?
relate to,
And by children, I mean pediatrics and
so that the
adolescents.
people online can see
What
it.
is the prevalence out there? Do children get these
Not,
cancers?
generally speaking, no. So the cancers that children get, and especially young pediatric patients, are not from acquired mutations. So everything that we're talking about is that through the course of our life, we acquire a mutation and a bad copy. The cancers that children get are typically mutations they were born with. Not because it's a family history, but in the process of making their body, they had that mutation. So colon cancer, and when I guess for clarity, when I say colon cancer, what I've been talking about is adenocarcinoma, is essentially non-existent in the pediatric population.
Awesome. And
There are other cancers that can be in the colon, but when we hear colon cancer, what it means is colon adenocarcinoma, which is a specific type. It's essentially non-existent in children.
That's awesome. And then my other question, and then I'll stop, is a little bit an outlier. And it has to do with, we're seeing a lot of colorectal cancers now in the hospitals with homosexuals.
Yeah, so there's probably I think I have two thoughts on that. One is in the homosexual male population in particular, they get a lot of cancers in the anorectal area. They're high risk for that. Technically, those cancers are squamous cell cancers more often than not. Not really the same biology of what we talked about today, but those cancers are associated with HPV, which is a virus that's prevalent on all of us. Used to really be thought of as a sexually transmitted infection, but is probably just a sexually transmitted or a physical contact transmitted virus. I think there was somebody out there today that had the table for HPV vaccinations, and there's a lot of cancers associated with HPV, which are squamous cell cancers, a different cell type. So anal cancers are technically, even though they're in the same vicinity, are technically not colorectal cancers. And the prevalence of pathogenic or cancer.
Yeah, it's red.
Is this one working? Can you hear me on this one?
Howie, we need another mic. Two. So the one, no, yeah.
Have you come across anything like that?
Nothing definitive. I think that there's some compelling research on the anti-inflammatory effects of intermittent fasting. The practical applications of it are hard. For a while, there was a very, very ketogenic diet that was given to cancer patients, which mirrored the intermittent fasting. It's hard because one of the priorities for patients who are undergoing cancer treatments is to maintain nutrition because of the medicines they're going to get. And so it's hard to know where that balance is. I could go days for fasting without affecting my overall nutrition, but somebody who's maybe lost a lot of weight, who's had surgery, maybe they can't. So there is good evidence to say anti-inflammatory behaviors have improvements in cancer outcomes, and there's good data to say intermittent fasting has anti-inflammatory properties. But can we say for sure that intermittent fasting has good cancer outcomes? We haven't made that connection yet. I give the same example with turmeric. So there's a lot of information that turmeric prevents or...
Yeah.
Oh, okay.
Yeah. Okay. I have this. Oh. Okay, so you're good? Alrighty. Hey, we are here at the JB Memorial Health Fair. And at this point, we're going to look at this contraption. But before we do, please introduce yourself, tell us your name, and tell us what this is about.
Absolutely. So my name is Iman. I'm an intern with the Parkland Cancer Program. We're just here to do a little bit of community outreach to talk about colon cancer screening, why it's important to get screened, how to start that process, and when you should start that process.
Fantastic. So what is this?
Okay, so this is the inside of your colon. So whenever it's time for you to start getting screened for colon cancer, right now the current recommendation is that you start screening at the age of 45. Most private insurances will cover it start at the age of 45. Some other insurances may start at the age of 50, but around then is about the typical age to get screened. When you get screened for colon cancer, the first step is they will give you typically an at-home test to take home. So this is a stool test that's going to be testing for any blood that might be present in your stool, called a FIT test or a Cologuard test. Parkland offers the FIT test. So the FIT test, you take it home and you send it back to the lab after you collected your stool sample. That will test to see if there's any blood within your stool. If they do detect any blood in your stool, that's when they will schedule you for a diagnostic colonoscopy. When they schedule you for a diagnostic colonoscopy, they give you some prep to take home. So there's some laxatives that you'll drink that will clean out your system completely so that your doctor can get a clear picture of your colon. So whenever they go into your colon, this is what they're going to be taking a look at. So right over here is the normal colon tissue. This is what you're hoping that they will see whenever they go in for your colonoscopy. You can see that it's all flesh covered, completely smooth, no irritation. So this is normal colon tissue. That's what they're hoping to look for. However, sometimes you can develop things that are called polyps. Polyps are fleshy growths that are lining the inside of your colon. They can develop just because of age. Your risk for polyps go up as you get older. Certain other risk factors such as smoking, alcohol use, or like a sedentary lifestyle can increase your risk for developing polyps. In this stage right over here, these polyps are non-cancerous.
Okay.
All polyps will start as non-cancerous. If they're found in your routine colonoscopy, they are easily taken out during the procedure, and that's it. There's nothing to worry about after that. However, not all polyps will stay like this. Some polyps, if left untreated, they can grow larger, and at that point, they will become malignant polyps, like seen right over here. These malignant polyps have gotten larger. As you can tell, they're a little bit closer together. They've developed cancer cells on top of them. These cancer cells means that they're no longer benign as they were seen over there. These are malignant and they have developed cancer. At this point, it's still pretty easily treatable depending on the person, but you know that you've gotten it a little bit too far. After this point, if it's still not treated here, that's when it'll develop into a larger colon cancer. As you can see, it's starting to grow into the walls of the colon. At this point, you can still survival for colorectal cancer, if found early and removed, can be pretty high. But the key to that is regular screening, because colon cancer can be prevented. If you're keeping up with your colonoscopies, you can get these polyps removed as they grow, and that will prevent them from ever turning into cancer. This is an advanced colon cancer. As you can see, it's spread into the walls. It's probably spread into other organs as well. So the farther it gets along, the harder it is to treat, as with any cancer. So there's certain things that can increase your risk for developing these polyps, such as any inflammatory bowel disease like Crohn's disease. This can be found during your colonoscopy. It's an inflammatory bowel disease that's on the lining of your colon. So if you have anything like this, that can increase your risk for developing polyps. But the best thing to do is to speak to your doctor about your individual risk factors, and they will help develop a screening plan. In addition to those lifestyle risk factors, if you have a family history of colon cancer, you might be recommended to start a little bit earlier. So it's either 45 is the typical recommendation, or 10 years before your closest immediate family member diagnosis, whichever comes first. But it's very important to talk to your doctor to learn about what your personal risk factors are and how you can prevent colon cancer from developing.
Thank you. Wow, that is a lot of information, but I love the visual. I love that you can see. So, as you said, it's really important that especially people of African descent to get screened for colorectal cancers, because they are on the uprise. Now, how I know we have information about Parklands, there's several tables talking about Parklands community outreach, but I want to ask you, how can I get screening through Parklands?
So through Parkland, if you're already an established Parkland patient, you're going to reach out to your PCP or your provider at the clinic and just let them know, hi, I want to talk about my risk factors for colon cancer, or I'd like to start getting screened for your colon cancer, and they'll start a conversation with you. Typically, they'll start you with that FIT test that you're going to take home. If you're not an existing Parkland patient, we do have some handouts that I can provide you guys with. It has our patient access line. You call that number, and they will let you know how to get into our clinics and get you guys on the wait list to get a provider. If you're on all of these FIT tests, they're covered by any insurance. If you don't have insurance, you're uninsured, uninsured or you're undocumented, anything like that, we do not discriminate regardless of status. We have patient financial assistance that will help cover these things for you to make sure that everybody can get screened because it's so important.
Fantastic. Thank you so much. And thank you, Parklands, for coming here and really supporting this health fair.
Thank you.
Today we have another specialty, another doctor, medical person. As you all know, I'm not a medical person. So I'm going to let him introduce himself, and then he will tell us more about his specialty. thank you so much for joining us. And so, okay, I know you as a dentist. Okay, wow. So in terms of what are the things that do you think that our audience could do or should do to prevent oral types of cancers?
Well, I think the same types of advice we get for most cancers applies here is making sure that we're eating a very healthy diet. That's one of the most basic things because that has an effect on your immune. There are habits, and we all have our vices, but there are habits like smoking and high alcohol consumption that actually plays a part in that. There are vaccines now for HPV, which really cuts down on the incidence of HPV-related or pharyngeal cancers. So I think from a preventative aspect, those are things that we can do at home. The other component of this is just to make sure that we're having regular exams with our doctors and not going on just when we're in pain, because that's almost always too late.
I completely agree. I think from what I hear is screening, going for those annual checkups, those twice a year teeth cleaning, which allows the doctor to examine your mouth, a dentist to examine your mouth. All those are really important. And I think as a culture and as a people, we have to start making that a priority, especially when you hear over and over from the practitioners here saying that people of color, people of African descent, sometimes many times don't have as great health outcomes especially in terms of cancer, and sometimes we develop more aggressive types of cancers. So I hope the thing that we all get out of this is, of course, healthy diet, exercise, but go to those checkups, those annual checkups, and dental cleanings and checkups as well.
The other component of this is obviously it's one of the things that we all touch on when we recognize the disparities in availability of healthcare. There are organizations out there that make it easier for people at all income levels to be able to get dental care. There are several organizations in the Metroplex that are doing that, and hopefully now with JB Mwangi Memorial, as we continue to grow and expand our capabilities, that's something that we'll be having a conversation about providing for the community. But currently, there are organizations like Mission Metroplex, Mission Arlington, the dental school in Dallas also provides some of these community facilities. So it's just a matter of if you're able to get the kind of care that you are looking for with dentists, have those conversations with them about what other facilities are out there that can be a little bit more affordable to them, so that access to care is at least circumvented as a barrier to the care you need and the screenings that you need.
Fantastic. I didn't know that. Can we share that information on the website? Can we get that information and we can share it on the Facebook page, the JB Memorial Facebook page? Like the page, because we will continue to provide information on that page that is critical and important for our health, and as he said, especially in relation to cancer prevention. All right, so Dr. Juba, what's your parting shot?
Well, we are looking forward to having more and more of these events that allow more and more people to get the information they need to better take care of their families, better take care of themselves, and have a healthier, happier life.
Fantastic. Thank you so much for joining us.
Oh, wow.
No, okay, I guess I thought I was told I was
I'm Simon.
Simon, and what's your specialty and what you're talking about?
So I am an acute care.
Acute care?
Yeah, acute care trained nurse practitioner.
Uh-huh. Okay. And so, oh, right now, yeah. All right. Can you hear me still? Okay, I can hear you. Can hear me. All right. Okay, we're gonna go, and I'll just let you all introduce yourselves. I didn't realize we were online, but anyway, I'll let you introduce yourselves, and we'll take it from there.
Okay. I am a Satatian, acute care trained nurse practitioner. Right now I work as an internal medicine critical care nurse practitioner with Medical City Health.
Fantastic. And what about the gentleman?
I'm a psychiatric mental health nurse practitioner. Currently, I work at Connection Wellness in Benton, but we are also all over the area.
Fantastic. So what attracted you to your particular specialties? I'm just curious.
So for me, it was a childhood dream to become a medical practitioner. Just, because of where we grew up, I wanted to have that hope to provide that care to my community. And it's a dream come true, finally, to be here. I know I'm not providing healthcare services in Kenya like I hoped and wished to, but hopefully someday, and I'm just glad that I am doing what I hoped to do.
Fantastic. Awesome. What about you?
For me, it's mostly experience. I've worked in different sections of healthcare. So, over time, I developed an interest in working in mental health. And I just find it so amazing and wanting to help people in that area.
Very good. I think mental health is one of the things that has become quite a bit of a discussion and comes up with the news quite a bit in the last few years and everything. So what are you sharing with our audience today? What are you sharing on this health fair? Because we are online now, and this Facebook Live is for people who were not able to make it or who are not in DFW. And so what are you sharing with the people in the health fair so that our audience can also partake in that information?
Yeah, for sure. I am manning the chronic health table or chronic disorders table. And basically what we are talking about is already established health conditions that each one of us have, that you have been told by your doctor that you have, and how can we manage that over time to prevent either an acute exacerbation that will land us in the hospital or land us into other risks that comes with some of these conditions. Some of the, it's a pretty broad topic, and we could go all day talking about chronic conditions, but some of the basic ones, it goes from very basic to very advanced to very severe illnesses, including just something basic as high blood pressure, high cholesterol, to advanced things like you have had a heart attack in the past. How can we live with that diagnosis and prevent complications that come afterwards? Things like having a stroke in the past, how can we live with the aftermath of a stroke? How can we maintain that to try to optimize living, quality of life, basically. So that is what we're discussing today. And I think the bottom line for most of these conditions is, you have a diagnosis that you have been told you have. The bottom line is to realize, one, do a little bit more research to know what that really entails, and know the risk factors, know the why we, most of the times your doctor will place you on some medications. Know the why. Why are we given some of these medications? It's basically to optimize your quality of life, to prevent risks, and to prevent other complications that come with that particular condition. So my bottom line is, you're given some medications by your physician, take them as prescribed. Do not take breaks, which I know a lot of us, we get tired of taking medications. You wake up one day and you're like, yeah, my blood pressure has been okay, I do not need to take this, or my cholesterol, my numbers are okay, I've been running and all of that. Take medications as prescribed. Do not take yourself off medications without checking with your primary care physician. And over time, just do the list of things that most likely your primary care physician has told you to do, and that will prevent us from landing in the hospital in an acute emergency.
Wow, okay, that's amazing information. But let me ask you a question. Help our audience. And as a person who is not from the medical field,
Yes.
I hear these terms and I ask questions, right?
Yes.
So, and I'm sure our audience is also thinking the same.
For sure.
What's a chronic disease or chronic situation?
Right. So a chronic condition is you go to the doctor, for instance, because you have not been feeling well. I've had a headache. I'm just really tired. I am just not myself, right? And you go to the doctor and they do a bunch of tests and they determine that you have, they name it for you. You have high blood pressure. You have arthritis. You have cholesterol, you have, things like that, things of that nature. And these are usually things that last or persist for more than 2 months at least. Mm-hmm. And some of these are like a lifetime of things that we have to deal with for the rest of our lives. So anything that has persisted for over 2 months is basically a chronic condition.
Okay, fantastic. Okay, that's a good thing to know. So if you have something, you have a situation, a health disease, a disease that's lasting more than 2 months, it could be chronic.
It is considered a chronic condition. Some of these are reversible, like with medications, and some of them are a lifestyle change, something that will be like a part of your story for the rest of your life that cannot be reversed.
Is diabetes part of chronic?
Diabetes for sure is a chronic condition.
Okay, so being that I know so many people and diabetes is on the uptake,
yes.
And this is not just here but also in Africa,
yes.
What are the things we can do? Is diabetes preventable? And if you have diabetes, as many people find themselves with diabetes now,
yes.
What are some of the things you can do to not end up in the emergency?
Thank you for bringing that up, because this is an epidemic that we are dealing with in the acute care world. Mm-hmm. So yes, diabetes, once diagnosed, it's usually a chronic condition. Mm-hmm. It just means that your blood sugars are way above where they should be physiologically. And the risk factors, what happens to cause diabetes, it's a bunch of things, some that we can prevent, some that we cannot prevent. Including just our genetics, being born into a family with a family history of diabetes. Those are things that we cannot change because we don't choose which families we get born into. But other things that we could probably, change in our lifestyle to prevent getting or acquiring a diabetic condition or a diabetic diagnosis, things like your own diet, things like exercise, weight management, our sugar intake. Those are things that we can prevent or we can modify to avoid a diagnosis of diabetes. Mm-hmm. Now, let's talk about, when that time comes, for whatever reason you have been diagnosed, we're here, we have diabetes, for any of the other factors. There are things that we can still do to modify or to mitigate the risks and the dangers of diabetes. For instance, you're diagnosed with diabetes, you're overweight, continue trying to work on your weight, continue to work on your cholesterol, continue to work on your diet, definitely. And along with that, you need to take medications that you're given, because once that diagnosis comes, you have diabetes, sometimes we need a little boost, and that's why our doctors put us on medications, is basically to boost our physiology, to normalize what is abnormal. Mm-hmm. So they will check your blood sugar. Usually it's an A1C or a lab called A1C, which measures the average blood sugars over like a period of time, usually 3 months. And they will tell you this is where your level is. They will put you on medications depending on what type of diabetes. I mean, diabetes is very broad too. We can go all day talking about the two
really?
types
Not
of
just the two?
diabetes. Yeah, there is two types of diabetes, but there's also maternal diabetes, and there
Oh,
are
okay, yes, that's true.
different. There are different faces to each one of them. But you're placed on medications. They usually either pills or you're placed on insulin. Please take that medication as prescribed. Follow up with your doctor closely. Check your numbers every day. Change your diet. Change your lifestyle, your exercise routine. And the thing that I think most of us do not understand is what are the risks of diabetes. It's not just having a number, like a high blood sugar number, and feeling bad that one time, but there are things over time that diabetes can cause in our lives. Untreated diabetes can cause loss of your eyesight. It can cause loss of your kidneys. A lot of people end up in end-stage kidney disease, needing dialysis because of diabetes. It can cause things like peripheral vascular circulation, compromise. A lot of people end up amputated. They either start losing their toes or lose their whole leg or things like that. But these are some of the things that we can either prevent the risks of diabetes or the dangers that come with this diagnosis. We can prevent, or we can at least delay them through a longer time if we can change our lifestyle, including managing your blood sugar numbers, taking your medications as prescribed, and then just honestly, keep that number where it needs to stay. Your A1C at least less than 6.7.
Fantastic. Well, that is really great information. And going back to, as you listen to this amazing medical information, please share, tag a friend. You might know somebody who is pre-diabetic, somebody who has been told they need to start watching their sugar. Can you tag them so that they can now hear this information and be informed and start to take the steps to manage the chronic situation? So I want to move on to mental health. And so tell us what you are sharing with the audience, out there in the health fair in terms of mental health. Go ahead.
Yeah, so on our table today over there, we are sharing about mental health. And mental health is mostly about self-care. So there is different diagnosis about mental health. We have depression, anxiety, we have difficulty sleeping, like insomnia, and other higher diagnoses like schizophrenia or bipolar disorders. But the most common ones are mostly depression and anxiety and insomnia. And then for children, we have ADHD, which is hyperactive or inattentive behaviors. There is also contact problems where they experience them in school, and also there is a lot of drug use in mostly in teens, but now even they start very, very early. And then there's also bullying in children in schools can cause a lot of anxiety. So we're just sharing that with parents and also talking to some teenagers who are attending the fair today. So also with our communities, we don't talk a lot about mental health. So we're trying to take that stigma away and just manage mental health as just another diagnosis like diabetes, hypertension, high cholesterol. And it's just mostly, if you have depression, it's good to get necessary care that you need, see a mental health practitioner, and if they prescribe medication, take them and don't feel bad about it. There's a lot of millions and millions of Americans or even other countries in the world that people have depression, they have anxiety. It's just something that happens to our body, and it's caused by different things that happen in our lives. Maybe, for example, COVID-19, it did cause a lot of depression, anxiety. There's traumas that happen. Maybe family member you were in a car accident and one family member passed away. That is a trauma, and that causes a lot of mental health. And what do? You can just sit down and not get treatment, because then it will spoil your whole life. You won't be able to function well. So it's just good to get the help that you need and don't feel bad about it. Just treat it as part of your body. It's health, and you just need to take care of it.
Fantastic. Oh my gosh. I have so many questions. I don't even think we don't have enough time to cover. This is what I would like to do. Down the road, I really would like to do a Facebook Live on JB Memorial and really want to talk about mental health, because you just covered from children to adults, and as you were speaking, I have all these questions coming to my mind. But maybe I want to touch on two things today, but I really would love to have this conversation.
Okay.
First question is, what is the relationship of stress and mental health?
Okay, that's a very good question. So stress, it causes some chemical imbalances in our brain. And sometimes our body, just the way the doctor was talking today, saying that, some proteins in our bodies can kill those cancer cells easily. Same thing with stress. Our body can manage it sometimes, but then sometimes it can't. So if it becomes chronic, then it becomes a problem. So because then you start having, problems with sleep, you start getting anxious all the time, you get so irritated easily, you start withdrawing from friends, you start not liking the things that you normally like to do. Some people even struggle with taking a shower or brushing their own teeth. And it's just because the stress that they were having has become chronic, and now it's depression and generalized anxiety. And it just becomes chronic, just like any other condition that we were talking about, like diabetes or hypertension. Because the stress level has become so high that now it's depression.
So when does a person, what symptoms are indicative that you might be depressed?
So if you are withdrawing from things that you normally like to do, those are usually we call it anhedonia. It's one word that we use it in healthcare called anhedonia, where you withdraw from things that you normally like to do. So, for example, if you normally like to get out with friends or talk with friends, now you don't like to do those things anymore. Maybe you normally like to go for a walk. You don't want to do that anymore. You usually like to get up on Sunday morning and get ready for church. You don't feel like doing that anymore. Even going to work is a problem. Going to sleep, you struggle with either going to sleep or staying asleep. So if that happens for a period of more than 2 weeks, then it's one sign that you are depressed.
That's important to know, because I don't know that we only hear people are depressed, but nobody ever really knows when should I self-check and say, okay, maybe I'm in a situation, maybe I need to go see a doctor. Maybe something is really happening
and
to
maybe
me.
You're at work, and you can't concentrate at work. You just feel like you don't want to do, you don't want to work at all. You feel tired all the time. Those are the things that then you know that, I'm probably depressed.
That's great information. Let me ask you one more question, and then really, honestly, we need to do an interview on Facebook Live, because there's so many things we can talk about mental health. So I'm going to go to the children. ADHD. Okay, all our kids are hyper. All our kids jump around and scream and do that. When do you know this is a problem that I need to go see a doctor?
Very good question. So, kids, it's good to let kids become kids, right? But sometimes, if you go to school, for example, and now the kid doesn't want to sit down, the teacher tells them, hey, you need to sit down, you are disrupting the class, and they don't listen to the teacher, and they're disrupting the whole class, and their grades are not good, and then even maybe they start having other conduct problems, impulsivity. They just do things, they don't think about it. They start fighting with other kids, then that becomes a problem.
Okay. So, what causes ADHD?
So there's no really a known cause of ADHD, but most of the times it's genetics. Some kids, they have genetics, but also just psychosocial, just the upbringing of kids. Some kids are brought up in very, very rough upbringing of kids. Some of them maybe stress can cause that. Others can be, trauma can cause that, so they don't respond well because they didn't get the love that they really are looking for. So those are kind of the things that cause ADHD, but there's nothing like specific, but genetics play a big role, and then the environment.
Wow, that's good to know. So, for both of you, we need to talk about diabetes. That is a huge topic. It's on the uptake in Africa. It's on the uptake here. And the thing that's surprising is so many young people, we consider ourselves young. We are in our 40s and we consider ourselves young, but we are finding ourselves, we have friends and stuff who are finding themselves being diagnosed with diabetes or pre-diabetes. So I think that's another conversation that I would love to have online, because we can't have health fairs every day, but we can have these conversations online. And so I'm so excited about the JB Mwangi Memorial page and this foundation, because it's a foundation where we can have these discussions and educate the population. So thank you so much for joining me today. Thank you for coming to the fair, donating your time, your resources, your education, your expertise. I am learning. Today I'm in school. I am learning so much, but thank you so much, and
You're
best
welcome.
wishes.
You're welcome. Thank you so much.
Thank you for having us.
All right. Wow. Okay. So we are out. We are. Yeah, you really are. This is. But you know what? That's the thing. A lot of all these practitioners, they're very.